All right, so yesterday we were talking a lot about thyroid. Let's start off with thyroid. We did mention different cancers that can happen involving the thyroid. First off, we said that patients, usually these cancers are related to radiation. So any kind of radiation that in their history and family history as well is related to this. Remember, the most common was papillary, but also we have to remember that um, these patients can come into the office with complaints of a nodule themselves. Typically, they can find the nodule themselves, and then they want to further follow up. They want to find out if it's cancerous, if it's benign. So they come into the office, and we said the mnemonic was URTI, like upper respiratory tract infection. It's just a
Yeah.
mnemonic of what you should do. Ultrasound, all right? Risk factors, TSH, and imaging. And the imaging was the iodine scintigraphy, the 123 iodine scintigraphy. So ultrasound, we mentioned a lot of different types of suspicious type of terminology that they can utilize. Suspicious terminologies like microcalcifications.
Irregular borders.
We mentioned irregular borders, definitely irregular borders, and these buzzwords, let's say, for these kind of suspicious findings on the ultrasound can also be utilized for different types of cancers as well. It's not only isolated to thyroid. So any cancer that gains the power of vascularity means that they are learning now to project themselves. They can now learn how to travel. They can also establish a route to receive more nutrients from the blood. So the suspicious findings are here on the screen. Remember, irregular margins, microcalcification, rim calcification with extruding tissue, extrathyroidal extension, just meaning that they're now projecting themselves further away. Cervical lymphadenopathy, and internal vascularity. So that's what we mentioned when we were looking at suspicious findings of the ultrasound. If there was anything suspicious and if the patient was positive for risk factors, we have to do a fine needle biopsy. Remember, we mentioned there was one cancer that has an issue with the fine needle biopsy, that we would have to do something, an alternative type of management in order to try to confirm its existence. You remember what it was?
Yeah, follicular.
Follicular. Yes, follicular. Now, okay, that makes sense. And remember, follicular is found in like 10% of these cancers. The most popular one, which one was it?
Papillary.
Papillary is correct. Papillary. Papillary cancer. Yes. This one is the most popular. And how does it look like on a histological imaging? What would we
Yeah,
find?
so all the P's and the Semoma bodies.
Yes, this one has Samoma bodies. That's correct. Can you recall? Yesterday we mentioned Samoma bodies. We talked about different cancers that have Samoma bodies. Can you name some?
Yeah, so we have the serous cyst adenocarcinoma, meningiomas, and the other one was, I guess, malignant mesothelioma.
Malignant
Yeah,
mesothelioma is correct. Yes. Yes, definitely. So here we have Samoma bodies. Papillary carcinoma of the thyroid. That's what we're talking about right now. Serous papillary cyst adenocarcinoma of the ovary. Meningiomas and malignant mesothelioma as well, right? Malignant mesothelioma was associated with asbestos. But then we said that there's another cancer that's more related with asbestos. You remember which one that was?
yeah, the bronchogenic carcinoma.
Bronchogenic carcinoma is correct. Definitely. Okay. So, yes, this is basically what you see, what would have Samoma bodies in general. This is what would come up with Samoma bodies. So let's look at the Samoma bodies. How do they actually look? We mentioned it yesterday. They kind of look like roses, right? If you look at them from above, they're kind of looking like roses here. They kind of have that morphological feature where they kind of look like roses. In every image that I see, even when we change up the colors, check this out. I have a white one here. Kind of looks like a rose, right?
Yeah,
All right. That's perfect. That's good. That's good. That's good. Let's continue. So, yes, we mentioned papillary. So, papillary is the most popular, meaning it's the most common. Papillary will have the palpable lymph nodes, right? And a lot of it happens post radiation. So, that's another P. Its histological features. Try to remember they have pupil nuclei, nuclei that kind of resemble a pupil like this. They call that orphan Annie pupils, right?
Yes.
Central grooving. They have something called Herthel cells. Herthel cells. Okay, perfect, perfect. So this is basically what you'll see in papillae. But now that we know so much about oncology, right? We have learned so much. Um, I would ask, what are the genes related to this? You mentioned two yesterday.
Yeah. So with papillary, we have the RET mutation, whereas with the follicular, we have the RAS mutation.
Yes, good, good, good. That makes a lot of sense. Is RET? Remember that RET is associated with men to A and men to B, right?
Yes.
And this one also has BRAF
Yeah.
association. So when it comes to BRAF, we mentioned some other cancers that are associated. What are the major two cancers? Well,
Yeah.
let's say
So
three.
okay. So we have melanoma. Then we have the hairy cell leukemia, and the 10 to 15% is colorectal carcinoma.
Yes, good, good, good. Hairy
John,
cell.
sorry to interrupt you, but I think there was this one, either one of these cancers which was related to the deficiency of iodine. I
Of
don't know if it's papillary or follicular. It's a risk factor basically. The
uh,
deficiency of iodine.
iodine as a risk factor, lower levels.
Yeah, like the deficiency. I'm not sure, but it just popped up in my mind right now.
Yeah, I'm not. It doesn't ring a bell to me. I'm not 100% sure. Yeah, I'll look for it though. We will look for it and mention it down the line. Iodine deficiency. I remember that can cause goiters,
Yeah.
and yeah, goiters they tend to be hypofunctional. So I can see why. I can see why they should have some kind of influence. But we'll take a closer look at that next time. Let's look. Let's keep rolling. Let's say men's disease. We just mentioned men's. So can you tell me men's disease? We have three different types. We have men one. What is found in men one?
So we have pituitary, all the P's, three P's basically, pituitary adenoma, parathyroid hyperplasia, and the pancreatic cancer, which can either be insulinoma or glucagonoma.
Insulinoma, glucagonoma, um, Zollinger-Ellison type, right? The gastrinoma, Zollinger-Ellison, glucagonoma. There can be many different types when we look at this. VIPoma, somatostatinoma as well. So if we're looking at all these different types of pancreatic cancers, let's just recall really quick. Um, Zollinger-Ellison syndrome. If you see ulcers in the distal part of the small intestine, ulcers at the distal side of the jejunal area, ileal ulcers, that's extreme because we have Brunner glands at these levels of the GI system where its job is to basically alkalinize that area. So if we have higher levels of alkalinization happening in the distal part of the small intestines, there's no way we should have ulcers. So if you see these ulcers here, you should be highly suspicious of Zollinger-Ellison syndrome, gastrinoma. Definitely, definitely distal ulcers. That's going to be a huge clue. Remember that you have an increase in gastrin. And in typical situations, when we talked about the stomach, we mentioned that normally, gastrin, do you remember what cells release gastrin?
Yeah, the G cells.
G cells, correct. And remember, this is, yes, you say, Jessica says distal to the duodenum. Yes, you can have duodenal ulcers. That is something that can happen, definitely, definitely. But if you start to see ulcers now going distal to the duodenum, that is very, very rare because we have Brunner glands that release higher levels of bicarb in order to neutralize the pH at that level. So there shouldn't really be ulcer formation. So whenever you see that, you should be thinking Zollinger-Ellison syndrome immediately. All right, so G cells. G cells is correct, yes. And remember, the main stimulus here, food enters. Food enters. Remember, you have chyme, it enters to the stomach, it will change the pH of that stomach area, and then you would have stimulus of these G cells. G cells is also stimulated by the vagus nerve, cranial nerve 10. Cranial nerve 10 stimulates the G cells as well. Remember, G cells are going to release gastrin. Gastrin goes where? To the blood, right? Stimulates the enterochromaffin cells, right? And
Yeah.
you end up releasing histamine as well. So histamine, acetylcholine, gastrin, what else? All these things bind to the parietal cell, right? Parietal cell is able to release hydrochloric acid. Hydrochloric acid, right? Does that make sense? Does that make sense? Yes,
Yes.
yes, yes. Good, good, good. Let's keep it rolling. Let's keep it rolling. Let's see. Let's see. So, yes, this makes sense. This is good. Perfect. That's what typically happens with gastrin. But okay, here in this situation, we're seeing an alternative scenario. What we're seeing is that there's a perpetual activation of gastrin. So the pancreas does have the power to release gastrin. So this is what's happening here at the pancreatic level. Now you have some kind of overactive stimulus that doesn't follow our feedback, doesn't follow the rules. It continuously starts a perpetual activation of gastrin, more and more acid being released. All right, so that's what happens with this increase in gastrin. These are G cells that are responsible. When we look at insulinomas, so yeah, insulinomas. I write very sloppy when I write fast, so it looks crazy. But an insulinoma, remember, your glucose will be low. Patients will have low glucose. Now, will the C peptide be high or low? Who can tell me? C peptide high or low? Anybody?
I think it will be high.
C peptide will be high because you are making your insulin from scratch. It's coming from the endoplasmic reticulum. You are making more and more insulin from the initial state, mRNA stimulus for more insulin. So insulin, whenever you make insulin naturally from your body, from your own body, it comes with C peptide. It comes with C peptide. C peptide detaches and goes off to the bloodstream. So you're able to use C peptide as a marker. You will be able to use C peptide as a marker. Okay, so what drug, what, let's say, what, when I take a certain diabetic drug, there's certain different oral diabetic drugs that we can take. There's one that will also, a couple of them actually, that increase C peptide. Can you name one? What drug will increase C peptide? Diabetic drug. Does anybody know?
Sulfonylurea.
Sulfonylurea is correct. Yes, yes, yes. That's perfect. Yes, sulfonylurea. Why? Because sulfonylurea will create the conditions to upregulate more and more synthesis of mRNA, which will make more insulin. Remember that. Remember, there's a depolarization phase. And if you're able to block these potassium channels, you would have more activation in the depolarized cell in order to incentivize more and more transcription of insulin. So you'll have more creation of insulin, basically, which will come with the C peptide. So if somebody overdoses on sulfonylureas, you should expect to see an increase of insulin with its C peptide, right? So if someone's taking exogenous insulin, I should not have an increase of C peptide. I should not have an increase of C peptide. So keep that in mind. All right, there's also something called VIPoma. VIPoma. For VIPoma, you will have watery diarrhea. Watery diarrhea. This is going to stimulate peristalsis. So it has a high peristalsis movement. The watery diarrhea here that you'll see will be accompanied with achlorhydria. Achlorhydria. Also, you will have a lower level of potassium, hypokalemia. All right. Also, remember somatostatinoma. Somatostatinoma. Somatostatinoma likes to inhibit many things. It's just an inhibitor at all times. So the issue here is that it's going to inhibit CCK. The inhibition of CCK is going to cause problems. It causes bile stasis, so it can lead to cholelithiasis, right? Stones. So that's going to be the problem here with somatostatinomas. You're going to see an increase of cholelithiasis. Perfect. That's the problem with somatostatinomas. All right, so that makes sense. We just mentioned a whole bunch of different types of pancreatic tumors in this sense. Remember that the 3Ps also include pituitary tumors. Now, what's the most common one? What is the most? Yes, prolactinoma. There's a lot of lactotrophic cells in the pituitary. So you will have activation of prolactin. Now, remember that prolactin can inhibit what hormone? Do you remember? It has an inhibitory effect towards what hormone? Anybody? If you know the answer, type it down. Let's see. What hormone is inhibited by prolactin?
Is it progesterone?
Nope. I'll tell you guys. I'll tell you. So check this out. Prolactin will inhibit GnRH. GnRH. Definitely. So let's understand this. Let's fix this. Let's make this clear. Let's make this 100% clear. Let me also show you some images. It can make a lot of sense so we understand this 100%. Because this is a little bit tricky if you think about all the different types of pathways. So, okay, let me see tuberole. Yeah. So if we were to look at the tuberoinfundibular pathway, yeah, what a crazy name they gave this. But nevertheless, this is what it's called. Tuberoinfundibular pathway. This is a pathway that will actively be inhibited by dopamine. So dopamine here is going to inhibit the release of prolactin. When you end up releasing prolactin, what ends up happening is that you then inhibit GnRH. So prolactin does have an inhibitory effect. And if it inhibits GnRH, we do need to know something important. GnRH stimulates FSH and LH. So hopefully we remember this. So I'm going to show you this image here. If we look at this image here, you can see that the lactotrophic cells are releasing prolactin. Prolactin will inhibit GnRH. So we have to understand, what does GnRH do in order to make sense of this all? GnRH will stimulate FSH and LH. So LH works in the will bind to the Leydig cells, while FSH into the Sertoli cells. Sertoli versus Leydig. Which one of these cells are responsible for spermatogenesis? Who can tell me? Where does spermatogenesis occur?
In Sertoli cells?
Sertoli cell is correct. Remember the mnemonic Miss Sertoli. Sertoli is responsible for the release of Mullerian inhibitory factor. Or what else? Inhibin and spermatogenesis. Spermatogenesis. Just learn these little mnemonics. It makes sense. You don't have to think about it too hard. Now you know the main thing that Sertoli cells can do. If you look at Leydig is responsible for releasing testosterone. Remember, ladies dig testosterone. Androgenic. Good. So basically, let me make it nice and clear. There's a tuberoinfundibular pathway. I'm gonna write it right here. Tuberoinfundibular. Tuberoinfundibular pathway is a pathway that's involved with the inhibition, let's say, of prolactin. You are inhibiting prolactin with dopamine. So D2 is what's utilized here. D2 second messenger system is GI, G protein I, inhibitory. So dopamine here is inhibiting prolactin activation. And this is what you see naturally. Hopefully that makes sense. Because if prolactin is released, If prolactin is active, then prolactin will have a direct inhibitory effect on GnRH. Let's see, this is the active version of prolactin. It will inhibit GnRH. And all I'm saying is that GnRH is responsible for activation of FSH and LH. Good. So what are the symptoms here? What are the problems? Well, with females, they'll understand this problem immediately. They would understand it in about a month, especially young fertile females, because they would realize that their menstrual cycle is not, they have amenorrhea basically. With males, it's a bit different. Males will realize that they have a decrease in libido. So it's a lot more like indolent, let's say, in that sense, when it comes to males, because they're not tracking a menstrual cycle. So you would see more, let's say, like when males will come to the office, let's say, they would have to be in a situation where it has expanded, it has evolved. So what phase, what level? If this prolactinoma continuously keeps on growing, it keeps on growing, it can definitely cause a bilateral, what is this called? Who remembers? When the patients have
Hemianopsia?
yes, bilateral temporal hymenopsia. This is when you have compression of the optic chiasm. Perfect. Remember that. Patients will have issues seeing things at the periphery system, and they'll have a problem basically acknowledging vision at the periphery. So the question can tell you patient bumps into walls. They can try to tell you like these kind of things. There's accidents, patient got into an accident. Remember that. Remember, we talked about this last time. Difference in how you can get the answer here. It's very easy. We talked about how easy it was. We said this was so simple, right? Hopefully everybody understands. There was one rule. The rule is that after this part, everything is backwards. After this section, everything is backwards. Meaning, if I have a lesion here, I would just do this. I would say, all right, this is the left side. Let's say this is the lateral genucleate nucleus. Lateral genucleate nucleus. Let's do this. If I say, okay, well, this is the left side, then I would have to say the appearance, the actual problem, the pathological features that the patient will have would be a right side, right homonymous, because both sides are affected, hymenopsia. Hopefully everybody understands. The rule is very simple. Everything is backwards. If I have a lesion here on the right side, then I would have to say left eye, right eye. It'll be a left-sided, left homonymous hymenopsia. So how does this rule extrapolate itself towards the bottom? Well, we have to remember Mayer's loop is pie in the sky, and the optic radiation, the other one, is pie on the floor. But as they come down lower towards the parietal area, entering like the occipital all the way in the back, you're going to see that they become the optic radiation here. So this is optic radiation, and so is this. This is just the inferior part. This is the more superior part. If you have damage here, you have pie on the floor. Damage here, pie in the sky. So what am I talking about when I say pies? Let's look at it like this. Look at the patient's eye right here. If you have damage on the right side, let's say here, Mayer's loop, right side. Remember the rule. I just have to say the problem is going to be on the left hemisphere. So left hemisphere, since it's pie in the sky. So all I'm going to say is that this is a left homonymous flangrantinopia. That's it. That easy. This is not difficult at all. If we're in the left side and I damage here, the floor, the optic radiation, pie on the floor. Look at the two eyes right here. Left, right. This is the left side. So on the right side, I now have pie on the floor. Yes, it is this easy. Believe it or not, it is this easy. So this is a right-sided homonymous. We say homonymous quadrantenopia. It's a quarter of it, right? Homonymous because both sides are demonstrating the same type of lesion there. If it happens back here, then it's a hymenopsia. It's going to be half of the hemisphere. But with macular sparing, that's just a little rule that changes here. Macular sparing, you do have macular sparing. It happens at the posterior part. Does everyone understand? Good thing we went through this really fast. It's just a recap. Definitely when we do neural, we'll go through this a lot more thoroughly, but it's just that easy. It's just that easy. Yeah. Let me see. I'm going to test somebody. Hopefully everybody understands. Let's test. Let's see if we can catch somebody. And we'll definitely learn this. We have this happening. So let's see. Lateral genucleate nucleus, lateral genucleate nucleus. Look how simple this is. All right. So let's see. Mona, it's not that I like to pick on you, but let's see. Mona, can I ask you a question here? And it's okay if you don't know. If you don't know, we'll do it. We'll go through it, work our way through it. So can you unmute yourself? Let's see.
Okay, I'll try.
Perfect. Perfect. Let's say I have a lesion. This is left side. This is right side. Right? This is the eyes. This is the nose. This is the temporal region. So let's say I have a nerve problem here. So these are my eyeballs right here. Left eyeball, right eye.
Okay,
What would this be?
so the right eye, like the part of the, like you're looking in towards the nose is affected?
All right. So you're saying is the temporal side or the nasal? That's what I'm going to ask you.
Oh, the nasal side.
All right. So let me explain. When we talk about the
Okay, yeah.
if we're talking about, so how do we describe these lesions? I'm just going to tell you one thing. Whenever we describe them, we try not to describe like what is damaged because that can get confusing. For example, when they give you the name of the type of lesion, they're not telling you the side that's damaged. They're telling you the deficit of the patient's vision. So a proper way to name, for example, let's say I want to name this. So things don't get too confusing. The way that they like to name it is that they would utilize the hemisphere that the patient cannot see, the one that he is lacking, in order to describe the lesion instead of describing where the lesion is located. You see what I'm trying to say? Instead of describing like what area caused this problem, they will describe the problem. That's how they give the name of these kind of optic issues, these optic lesions. So for example, this I would name, it's on the right side. So I say right side, homonymous, meaning that they're both identical in their disorder. And then I would say either hymenopsia if it's half or quadrantenopia if it's a quarter. That's how they describe it. So what you said, technically, you're not wrong because it is messing with the nasal side. But this is the thing, the nasal side transmits the vision for the temporal. Does that make sense?
Yeah, so both temporal sides will be affected.
All right, so yeah, let me explain.
Oh, oh wait,
So,
hang on.
so
No. One side, okay, I'll let you explain.
yeah, let me explain. This is going to be super easy from now on. All you have to do is this. You're thinking too much about it. When you think too much
No,
about it, it gets
because
confusing.
the first aid also has this issue because they describe it, but then they tell you the opposite. Like it'll say the left, and then the picture will show the right. Yeah.
So check this out. This is how easy it becomes. This is left side. This is right. Check this out. if I have a lesion here, all I have to do is say this. Okay, my lesion is in the left. Therefore, the problem will manifest itself on the right side of these eyeballs. It's opposite. So if it's happening on the left side, let's say this here is the left, I would automatically say, okay, in the right side of the eye, I have a problem. Now, if it's happening here at this portion, it's an hymenopsia. It's half. So this is how easy it is. If it's on the left side, all I have to do is go to the right side of the eyeballs and say it's a homonymous, meaning same issue. Homonymous hymenopsia, meaning half, hemi. So that will be the problem that would present in this type of patient. So instead of giving it deep thought, instead of giving it so much deep thought, all you have to do from now on, for example, let me show you another example. What if the patient has an issue here? Let's say this is the right side. You see that? I would just do this. If it's the right side that's affected, automatically I know that the issue is going to be here on the left. Automatically. If it's the right side that's affected, I already know that the issue is on the left hemisphere. So this is a lower portion. Here they have united already. Mayer's loop and optic radiation has united. So I would have to say this is going to be a left side homonymous hymenopsia with macular sparing. Does this make sense, Mona? Let me know. And if not, let me know what does not make sense so I can try to clear it up. Definitely. So let me know. Does it make sense or no? Tell me where it becomes weird.
Yeah, no, it makes sense.
Does it make
Because the
sense?
bottom one, the optic, like,
Radiation.
is preserved, right? Like the central part is.
Yeah, the central part gets preserved just because of this finding that already happened. But that's neither here or there. It's just all about looking at where there's a lesion and being able to describe that lesion. It's like if I tell you, it's it becomes, let's see, for example, let's say this is the lateral genucleate nucleus. I made it a circle instead of a square this time. Hopefully it's not confusing. But all I'm saying is this, for example, the rule is if I have damage of one side, automatically the left hemisphere. This is damage of the right side. You see that? That means that the left side of both eyes will have a problem. That's it. If you could connect that and you could just make that strong connection, then you can get the answer. You can find out where the lesion is whenever you find a question like this. It's just the opposite. Always. All right? Does that make sense? Does that make sense? Let me know. Good, 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 good. Yes, yes. And anybody who doesn't understand, you can rewatch the video. I'm going to upload it. Rewatch it slowly if you have to. It's just saves you so much time. There's so many tricks in neural. Whenever we do neural again, we're going to talk about all these. I'll just make a class based on the tricks of neural because you don't have to think things through thoroughly all the time. Like the way that in order to distinguish if it's superior or inferior, you have to know if it's Mayer's loop or optic radiation. Optic radiation down here will be inferior. Fine Drantanopia, a quarter. If it's superior, then you know it's up here. Oh, hold on. I should be drawing it correctly because this is the left side. Therefore, it'll be the right side that would manifest with the problems. So Yeah. Just know the superior level, how to connect that.
Yeah, this part I understand. Like if it's more internal, then it's looking down. The one that's like I guess more lateral versus medial, it's looking up. So it's trying to like outside is going up and then inside is going in and down.
All right, that sounds super confusing.
That
That
sounds
would
confusing.
yeah, that would confuse me. What I just do is this. I think about it like this. There's two loops. One loop that's in the outside and one loop that's in more towards the inside. The outside loop is the mayor's loop. I think about a mayor eating pie. For some reason, that image just goes into my mind. So I think pie in the sky is mayor's loop. Mayor's loop is the outside one. The inside one is the optic radiation. By default, that's the floor. That's pie on the floor. So the inner one is the optic radiation. Now, what I do kind of like, I don't like at all, is that when these two things unite and they continue all the way down, then they call it optic radiation as well. Like they should have gave it another name. But down here, this lower portion is also optic radiation. So it's like, come on, guys, that doesn't really help too much. Um, so yeah, yes, same thing on the other side, same rules. This side, this is makes it a lot more simple. I'm going to make a class just based on easy ways to get your answer on neural. And this is one thing that can be simplified. There's cranial nerves that you can diagnose where the problem is. Very simple by looking at several things as well. But the thing is, we're talking about oncology. This all started because we were talking about optic chiasm. The optic chiasm can get compressed in any kind of patient that has tumor arising from the brain. It starts to push forward towards the optic chiasm. Now, this optic chiasm is below this level. So remember, the rule still applies to the optic chiasm. The rule still applies to the optic chiasm, meaning that if there is some kind of issue, some kind of compression towards the middle portion, the medial portion, the nasal portion here in the middle, the opposite will have a problem, meaning bitemporal hymenopsia. It still goes with this rule. This rule is so strong, it still stays with it. You see, your lesion is here in the middle, yet you manifest the opposite type of problem. You see what I'm trying to say? When does it not become like this? When does the rule does not apply? After this point. This here, if it messes up the left optic nerve, then you would have a monocular. The whole eye will be messed up. Left eye. Does that make sense? So yeah, keep that in mind. Keep that in mind. Keep that in mind. All right, let's continue. Let's continue. That was crazy. That was a crazy deviation, I would say. Yeah, so we were talking about pituitary tumors. We talked about prolactin. We mentioned the power of prolactin, how prolactin can actually cause this type of stimulus, right? So let's recall as well. Let's say there's a patient who has a decrease in T3, T4. Decrease T3, T4. TRH will increase. What does TRH do to these type of hormones here at this level? Who can tell me?
So TRH, it basically activates the prolactin.
Activating prolactin. Activate prolactin, you automatically inhibit GnRH. Same story. Same story. What else activates prolactin? Patients who are taking antipsychotics, especially those atypical types, the types that inhibit D2. You inhibit D2, now you have inhibition of the inhibitor, which was dopamine. Now you have activation of prolactin, leading to inhibition of GnRH, FSH, LH. Does that make sense, everyone? Does that make sense? All right. All right. Let's creep ourselves back into slowly into onco. We took a crazy deviation there, but it's all good. It's all good. That's what I mean. That's what it's about. Just deviating, making sure that we touch up on topics so we don't forget about them. Okay. So yeah, we were mentioning pancreatic type of tumors. Then we mentioned pituitary. We mentioned prolactin. Okay. So let's continue. Let's talk about parathyroid adenoma. Parathyroid adenoma. Okay. So what happens here? Here you'll have an increase of calcium. Increase of calcium, right? Does that make sense? Increasing PTH leading to an increase of calcium. Now, when calcium increases, one thing that we should know is that it causes desensitization. It causes an issue with ADH and the collecting tubules. So ADH has an issue binding with the collecting tubules. So you should expect your patient to have a nephrogenic diabetes insipidus when he has an increase in calcium. That's something that we can see. So the patient will have polyuria, polydipsia. Polyuria, polydipsia, like a diabetic type of patient. It's kind of crazy if you think about it. So that's something that you can also see in this sense. And not only that, but calcium loves to bind to a lot of things. Calcium loves binding things. It binds oxalate, binds citrate, binds many things. Remember that. For example, if you are giving a blood product to some patient and it has a lot of citrate in it, well, calcium can bind it, and then you'll have a lower level of calcium in your bloodstream, right? Paresthesia is what you'll get, things like that. So just remember, calcium loves to bind other types of amino acids, any kind of macromolecular structure, including fats. Calcium loves to bind fat as well, which you can see in the level of when we talk about saponification and pancreatic damage. So one thing that we have to keep in mind is that calcium can bind, let's say, other types of products in the kidney, lead to kidney stones, right? It's huge when it comes to kidney stones. Calcium, hypercalcemia causes kidney stones, right? Remember that. Let's keep it rolling. Let's keep it rolling. Men2A. So Men2A, who can describe to me Men2A? Type it in the chat. Type it in the chat of anything. Men2A, what does it have? What do we have with the Men2A? Men2A. Parathyroid hyperplasia. Okay, I like that one. That one makes sense. And we talked about that one. So that one's good. We also have pheochromocytoma. Pheochromocytoma. And medullary carcinomas. Good, good, good. Thank you. Thank you. That is great. So, all right. Now we're talking about medullary. Look at what happened. We started talking today about thyroid. We said thyroid have basically 4 cancers that we should be aware of. We have papillary, we have follicular, we have anaplastic, and then we have medullary. So now we're talking about medullary. Let's plug this into the thyroid problems. So medullary, basically, it has, all these cancers that we were mentioning with Men2A are RET gene problems. Remember that RET is an oncogene that can activate transcription factors. It's responsible for the activation of transcription factors, leading to more and more activity of proliferation, right? This is how it's working. This is how it's working. And it likes to work via tyrosine kinase activation. So keep that in mind. All right, so pheochromocytoma. In pheochromocytoma, remember, you have an increase in catecholamine release. Remember that the supraadrenal glands, we have different layers, but inside the medullary layer, you have the enterochromaffin cells, right? And these cells are a derivative of neurocrest. We always mention that, crest. So yes, you'll have a release of this norepinephrine, epinephrine. So whenever norepinephrine, epinephrine are at higher levels, at high levels. We can even include dopamine. All of them bind alpha 1. Norepinephrine will bind alpha 1 regardless, but they all tend to bind alpha 1 when you're giving them at higher dosages. Remember that. All of them. That's the rule of catecholamines. Whenever you distribute catecholamines at high dosages, they all have affinity for alpha 1. Now, at a normal dose, you'll see that epinephrine kind of looks like a B, So it does have affinity for beta. That kind of leads you to think, remember that at the lungs, we do have beta 2. And beta 2 has to do with bronchodilation. It activates bronchodilation. If you agonize, if you have agonistic effect upon beta 2 receptors, you would have bronchodilation. Now, M3 is the opposite. If you do agonist effect to M3, you'll have bronchoconstriction. So these two receptors are battling basically for control of the bronchial system. Now, when you give when you give epinephrine, you'll realize that it wouldn't really manifest with vasodilation, although you do have beta 2 in the vessels. That's only because epinephrine also has alpha 1 coverage. Yes, it favors betas, but it also has alpha 1. And it has just enough alpha 1 to stimulate constriction. So in the vessels, it'll stimulate vasoconstriction. In the lungs, it'll stimulate bronchodilation, which is why we can give epinephrine in situations of anaphylaxis. Remember, anaphylaxis is very, very, very different than sepsis. Two completely different things. Anaphylaxis has to do with IgE activation on the mast cells. Remember, mast cells, they have IgE right in their surface. What ends up happening is that this IgE is primed already. It has sensitized itself to a certain type of allergen. So when we make contact with this allergen, IgE will bind it and it will increase the amount of receptors in its surface. Receptor aggregation, we call that. Receptor aggregation. Then it will cause something called cross-linking. All the receptors will cross-link together. Then you have cross-linking. Then, of course, you'll have degranulation. So that's anaphylaxis. The problem is with anaphylaxis, you have release of leukotrienes. You have release of histamine. You have release of many pro-inflammatory factors, but the leukotrienes will lead to bronchoconstriction, which is why in anaphylaxis, we can treat with epinephrine. Because epinephrine, like we just mentioned, has beta 2 and alpha. So it will help out with counteracting the effects of histamine and counteracting the effects of leukotrienes. Leukotrienes try to cause bronchoconstriction. Remember that they're potent bronchoconstrictors. Good. Sepsis, a completely different story. Sepsis, we mentioned when you have the gram-negative. Remember, gram-negative is going to have LPS. And then you have, of course, your macrophage. This story should be so repetitive at this point, having the toll-like receptor. When these two things meet up, they release NFK beta. Remember that NFK beta will release a bunch of cytokines. Cytokines like tumor necrosis factor alpha, pro-inflammatory proteins as well, like tissue factor. Pro-inflammatory, like activation of complement. These things will lead to anaphylaxis. I'm sorry, not anaphylaxis, sepsis. What did I say? Sepsis. So the main problem in sepsis is going to be that dilation. You're going to have an excessive amount of dilation. Therefore, you can give norepinephrine and you give IV solution, a lot of IV solution. and you have to know what the culprit is that's causing this. And then you have to treat it, definitely. Keep that in mind. Keep that in mind. All right, we continue. We continue. Wow, this was a crazy rabbit hole we went into with pheochromocytoma. But okay, we continue. Phenoxybenzaprine is this drug that we can give, and we supposed to give this drug before a surgery in order to make sure that we can block the alpha receptors. There's also beta receptors that get blocked as well. Remember that patients will come in, they have episodic type of issues. They'll tell you that they have episodic increase in blood pressure, going as high as 200 even, exaggerated. That's what you basically end up seeing. Hypertension, headache, and increase in catecholamines. In the urine as well, you should have metabolites of the catecholamines present. Definitely. All right. For medullary, completely different. Medullary has to do with what? An increase in what? Who remembers? With medullary thyroid cancer, we are increasing what? Calcitonin. Yes. Calcitonin. Calcitonin tones down your calcium, tones it down. Tones it down. All right. Good. Meant to be. Who can tell me meant to be? What does meant to be have? Anybody? What does meant to be have? Meant to be. Medullary carcinoma, again, yes, we explained that. That's good. Pheochromocytoma, yes. And then the last one, the mucocutaneous ganglioneuromas, definitely. And with marfanoid features. Patients have marfanoid features. Yes. Good. That's what we see with men's disease. Definitely. Wow. So many crazy things. Yeah. Like if we get into it, there's a way to get into it a lot deeper, but yeah, let's not do that. Let's just go into now. We mentioned the thyroid, medullary. We mentioned papillary. We said what was positive. What is positive for follicular? Let's go on to follicular. So P was the first one. We said that P was papillary. We mentioned that with papillary, you had BRAF that was positive, right? We mentioned BRAF. We also said that you were RET positive. So for papillary, well, yes, for follicular now, we're talking about RAS. Follicular, we have RAS that's positive. Everyone remembers RAS, right? RAS was that that membrane protein that gets activated. Remember, when you have receptor tyrosine kinase activity, follicular is the one that has an issue with the fine needle. Yeah, you can't do the fine needle. So follicular, remember, it has the Fs. So follicular, far away metastasis, meaning that the metastasis is hematogenic metastasis. Hematogenic. Yes. FNA, the fine needle aspiration, does not work. So that one does not work on these type of patients. What else? We also said it has is for females. A lot of females are positive on this. And it has invasion of the capsule as opposed to papillary, which does not have invasion of the capsule. That's one thing we could remember there. So RAS is the problem with follicular. RAS is the problem with follicular. Medullary. Okay, well, hold on. Let's go to anaplastic next. So anaplastic. For anaplastic, it has a terrible prognosis. Remember, it's not following any rules because it's earlier on the differentiation stage. It's less differentiated cells. Anaplastic is affecting the elderly. And what's wrong with it? P53. P53 is the problem. Good. And medullary, we already mentioned medullary. We said medullary is a RET problem. We find it in men 2A, men 2B. We said that medullary also is composed of amyloid. Remember that, amyloid. Good. Perfect. Now let's keep on moving. Let's keep on doing other things. Let's keep on pushing forward. So let's see what's going on with myelocytic cells. Yeah, this is the topic that I always want to touch up on, and then I end up talking about something else. So first off, let me show you guys an image. If we're looking at myelogenous lineage, let's understand first myelogenous lineage. Remember the bone marrow. The bone marrow is composed of cells that are basically going to be precursors that are going to differentiate to give us our cells here. So you guys can see this, right? Anybody see that? I think it should be, yeah, it should be on the screen. All right. So here we're able to see that there is different type of lineage. And we talked about this before. And I mentioned something very interesting. Well, it's interesting to me. Don't know if it's very interesting to the world. But the idea of pyrimidine synthesis having a lot to do with the myelogenous type of cells. And then the purine synthesis having more to do with the lymphocytic cells. Also, the idea that purine has to do with a lot of uric acid buildup as well. So remember that. Remember that. So definitely, this is interesting if you think about it. And we can make connections. Remember, when you have a lack of B12, you'll have megaloblastic type of anemia that we saw on the de novo pathway with that step of dihydrofolate reductase. Also, if you want to, for example, increase your, well, also we mentioned neutrophils, hypersegmented neutrophils. If you lack B12, you have hypersegmentation of neutrophils, where they have 5 lobes instead of 3. So you're seeing how things that affect the de novo pathway in the pyrimidine side can manifest itself with some kind of morphology change, some kind of change of these myeloid cells. So that's something that we did mention. So if we were to understand these type of cells, there's something that we do need to take into consideration. It's a rule that we also did mention yesterday, has to do with differentiation. As these cells differentiate, they start to change and turn smaller. They start to follow more rules. They start to express less, let's say, receptors, like CD positive type of receptors. They start to then differentiate to more specific type of cell that has a specific type of function. I'm talking about both myelogenous, both lymphoid cells. They'll be like, they'll differentiate and they'll express less CDs, and they'll get more specific in their action. Right. So this is not going to turn into a lecture. I'm just letting you guys know simple things. For example, if we look at things like myelogenous, myeloproliferative type of neoplasms. So we're looking at these kind of cells, let's say. Right. Polycythemia was what we saw with RBCs. We saw polycythemias. Polycythemia. We were able to mention all different types of issues here. Does somebody remember what protein is wrong here? What kind of gene was the issue here that's driving this polycythemia on these kind of patients? Who remembers the cause of this? JAK-STAT. JAK-STAT is correct. JAK-STAT problem. And it's the same issue with all the precursors of these kind of cells. So megakaryocytes. It gets a little more extensive. They didn't include everything here, but the megakaryocytes, the cells that are responsible for, let's say, for the platelets, right? Essential thrombocythemia, where you have a whole bunch of huge types of platelets as well. So it's all JAK-STAT. It's all JAK-STAT, including this one condition that we mentioned yesterday, which was the myeloid, what was it, the fibrotic one? Did somebody remember that? Myelofibrotic? It's definitely leading to myelofibrosis. Remember, this was an activation of perpetual activation of TGFB, promoting more and more, let's say, scarring, more and more fibrosis inside the bone marrow. So what was very pathognomonic of this was the teardrop cells, the cysts, the darkocytes. When they look like in peripheral blood smear, they'll look like teardrops because on their way out, they're getting ripped. It's getting sheared. That makes sense. Dry tap. Whenever you do a bone marrow biopsy, you do a aspiration of the bone marrow, you have a dry tap. Remember, this was all the conditions that we were talking about yesterday. This was myelofibrosis we were talking about. And we said that the treatments for all of these lineage kind of cells, remember, we said hydroxyurea. That makes sense. Hydroxyurea. Remember why this makes sense? Because of the main idea of everything that we're preaching. It has to do with the de novo pathway, right? It has to do with the buildup of nucleotides in the de novo pathway. So yes, I'm going to repeat that because that is true. So you're seeing that, of course, you're going to give a disruptor of that de novo pathway. Let's take a look at that. Let's see how that looks. So here I'm going to put it right next to it. It makes sense that if the de novo pathway is so important here for pyrimidine, look, we're giving hydroxyurea to inhibit ribonucleotide reductase as a treatment for these kind of issues, right? For these myelofibrotic type of issues, for these essential polycythemia vera, essential thrombocytosis, for all these problems. You're seeing the treatment is standard for all of them, hydroxyurea. And if you cannot give hydroxyurea, the second line that we mentioned was something called ruxolitinib. Now, my question is this, everyone. My question is this. Ruxolitinib. They have so many weird names, I'm telling you, so many crazy names. But one thing I do know about this drug, let's say I don't know anything about the drug. Let's say I just saw this drug from a piece of paper. Don't know any idea of it, but I see that it ends in nib. Nib. What's the mechanism of that drug? What is the drug actually doing? Inhibitor of kinase. Yes, it is inhibiting kinase. Now I know it inhibits kinase. Keep that in mind, right? Typically, the kinase that gets inhibited a lot of times is tyrosine kinase, because tyrosine kinase is like the initial stimulator for a second messenger system. So it drives a lot of effect. But there can be other kinases as well. Like we saw yesterday, there's drugs that are given to patients to inhibit the BRAF reaction in patients who have melanomas. Patients who are prone to melanoma because of BRAF, you can inhibit their BRAF kinase. With that drug, it was called yeah, it's crazy to spell these drugs. That's just my only problem here. I can't even try. It was let me get the name of it. It does end one thing I do know about the spelling is that it does end in nib. Let's see. This was for melanoma. Let's get the spelling correct. Yeah, definitely. Here goes. It's called, let me put it right here. Here it goes. Everybody can see this. This is inhibiting BRAF because BRAF is associated with melanoma. BRAF was part of that second messenger system where RAS was activating RAF. In the end of it all, it activates MAP kinase. Then you have some activation of transcription factors. So yeah, I urge everyone to try to at least learn the superficial part of it. Don't need to go too deep. There's so many different kinds of proteins that are doing cell signaling. But when it comes to like mitogenic effect, when it comes to cells trying to proliferate, trying to run the cell cycle. Yeah, yeah, I'll answer that down the line. But okay, let's see. Hydroxyurea. That's what we're giving for this type of treatment. So let's keep it jumping. Let's see what happens next. Okay, we said that myelofibrosis, we mentioned already the pathophysiology of it. It's basically promoting more and more fibrotic effect inside the bone marrow. So let's continue. We also mentioned, all right, so let's look at now these type of problems, these type of lineages that we have like when it comes to leukemias. So leukemias, they're malignancies of white blood cells, right? They are actually putting cells out to the periphery system. That's going to be the major problem. So there's two things you should think of when we're thinking of these kind of leukemias. Two things that come into mind. You should organize your thoughts because a lot of people get confused. There's so many different clues and things everywhere. So you can't be scattered when it comes to this. If I'm thinking that there's something that's invading the bone marrow, and this something, whatever it is causing an increase of cells on the outside of the bone marrow, I have to be aware of two things. One is that the cells of the bone marrow are now being occupied by malignant cells. So the cells that were there, that were functional, that I need, are not there anymore because they're now replaced with malignant cells that don't follow the rules and are not here to help me. So if that's the case, I will have complications that have to do with bone marrow insufficiency, let's say. So my immune system will be low. So I have a low level of immunity. Hemoglobin low. I should automatically start to see myself as an osteopenic type of patient. Although the products that are being put into the bloodstream, it could be a little tricky because it looks like you're putting out a lot of white blood cells, let's say. But in reality, what are you really putting out there? You're putting out these immature, non-functional type of white blood cells out to the periphery system that's just causing more and more complications, actually. Does that make sense? So to organize it, let's look at it like this. If the patient, for example, let's say there's different lineages. There's going to be myeloid, lymphocytic, right? And I could tell you that the immature cells, we can call them blast. Blast. They have, let's say, for example, AML versus ALL. What does that mean? I have to learn this language. Acute means that it's happening at a, let's say, a very early type of differentiation stage. So let me show you guys an image. I think the best way to show it off will have to be an image. Image is a lot better. Here you go. So if we look at it like this, myeloblast, promyelocyte, neutrophilic myelocyte, metamyelocyte, band. Band is officially immature neutrophil. And finally, you have your mature segmented neutrophil. If it's acute, it's happening at a very early stage, happening very early on. If it's chronic, it's happening later on. Does that make sense? So their name is telling you so much. Their name tells you everything. Their name tells you everything. If it says AML, it's telling me, okay, well, it's acute, meaning it's very early on. So it's going to have some features that are kind of crazy. It's going to have some wild features. What do I mean by wild features? AML has things like our rods, for example. They're going to come with some components that we're not ready for. And it's going to be MPO, myeloid peroxidase positive, and it will have our rods. Remember, our rods are able to activate the coagulation cascade. What can our rods cause? Anybody remember? What can our rods actually cause? Anybody know? Our rods. When you activate them, what do they cause? Anyone? DIC, yes. Good. Thank you. Yes, that is true. That is 100% true. It can cause DIC. It can cause DIC. All right. So basically, this is more of like an introduction for the next class that I'm going to give in oncology. Because the next class, we're instead of a drill, we're going to have to actually go into it and do questions on this, because I think this is the best when it comes to oncology. The best way we did do a question session before. We did it based on the foundational resistant mechanisms of cancers. But one thing that a lot of people have problems with is these kind of questions: CML, AML, all these different types of leukemias and lymphomas. We're going to include lymphomas as well. So in the question sessions that we do, it's all going to be lymphomas and leukemias. Lymphomas and leukemias, and I'll show you a strategy to try to approach this in an organized way. In an organized way, so you can try to get the answer. There are certain tricks that you can do. There's certain things that if it's there, then you go pick that answer. There's certain things where the clinical vignette can be very long, but if they gave you some features, then you can pick it right away. You don't have to worry. So we'll look at that in the question sessions that we do. I'm preparing the question sessions with lymphoma is going to be lymphoma and leukemias. We'll do examples of all of them, and we'll break it down, show you a strategy to approach it, so that way we're not confused and going crazy whenever we read a question. With a lot of MBME questions, actually. So that's the approach. Definitely can't just drill this material out of nowhere right now, because the material that it needs a lot of explanation. Like owl rods, for example, yes, it causes a DIC, but there's a lot of other things as well with AML that we have to take into consideration. The subtypes, there's a 1517 one that's the most common type that you'll see for this exam. I'm not saying it's the most common, but for this exam, it is very common. They like to put this one, maybe the only one that they will like to put, but something that's very interesting, let's say, is that the most significant number of R rods are found in the promyelocytes. So promyelocytes have a whole bunch of R rods. So it makes sense that AML are releasing a lot of promyelocytes, leading to the activation of DIC. These R rods are like little sticks. I wish I had an image of it. Oh yeah, I do. Check this out. This little stick right here. When this makes contact with our bloodstream, it starts to activate the extrinsic factor, the extrinsic side of coagulation cascade, leading to DIC. Leading to DIC, this right here. That's what we call the owl rods. So what happens here is that the problem with 1517 type subtype is that as this is differentiating, it puts a halt to the differentiation. It says no more differentiation, but it doesn't put a halt to the proliferation. So you do have proliferation. Proliferation is still there, but you have no differentiation. So if you have proliferation without differentiation, you end up making a lot of precursors, promyelocytes. So what activates differentiation in these type of patients? A miracle drug, which is just vitamin A, retinoic acid. It's been seen to promote the differentiation. So proliferation without differentiation is terrible. It's you making a whole bunch of precursors. Proliferation with differentiation is great. It's you making neutrophils. So that's how retinoic acid will work here, for example. So remember that. Yeah, there's so many things that we can talk about. That's just basically for like treatment of APML. That's the subtype of 1517. Remember that promyelocytes, yes, definitely are the ones that are going to be causing DIC. And DIC, so we look at DIC. DIC versus HUS. DIC versus HUS. Let's understand what's going on here. First off, just let's let you know. Technically speaking, E. coli can cause both. Technically speaking, both can be caused by E. coli, right? Because if you think about it, E. coli, you have EHEC, and EHEC has basically verotoxin, can activate these type of things. The Shiga-like toxin at the level of the bloodstream. right? It can activate this type of problem with HUS. Now, remember HUS has RAT, renal insufficiency, microangiopathic hemolytic anemia, and thrombocytopenia. So what's the issue here when it comes to this? Well, you have damage of the endothelial cells from the exotoxin called viral toxin or Shiga-like toxin. You damage endothelial cells and you end up having the deposition of, let's say, fibrotic deposition like this. So you end up creating an issue where whenever RBCs go past this level, they end up getting shredded. You also shred platelets. They also end up getting shredded. But you're not activating the clotting factor. Let's be clear here. You're not activating anything that has to do with clotting. So in HUS, PT and PTT should be normal. You should have an increase in bleeding time, yes. Bleeding time increase because of the shearing of the platelets. But everything else, when it comes to PT and PTT, should be normal. DIC, so what's up with DIC? DIC was what we mentioned before, when we had a gram-negative binding to an antigen-presenting cell like macrophages. Remember the toll-like receptor stuff, super high yield, LPS. LPS is made up of lipid A. Lipid A activates many different things, including complement, including tumor necrosis factor alpha, but also including tissue factor. Tissue factor can stimulate, can activate clotting factor 7 in order to stimulate the common pathway. So you'll basically be running the coagulation cascade on both sides in this situation, but stimulating it from the extrinsic side with 7, leading to a increase in PT and PTT. That's what we see at the level of DIC. So you're seeing how E. coli can actually cause both if you think about it. But here with our rods, they're here. They're activating, they're reacting. And once you have that reaction, you'll end up stimulating this same thing, the same pathophysiology right here. Consumptive coagulopathy, consuming the clotting factors. Hopefully that makes sense. That's DIC. It can be found in situations with owl rods. The promyelocytes are the cells that are responsible for carrying so many owl rods. All right? That's an issue that we have. So we have to promote the differentiation. We just said that giving retinoic acid will help in this sense. This is 15, 17 subtype. 17 is where you have the retinoic acid receptor. So that's what you have happening there. Definitely that makes sense. This consumptive coagulopathy as well, not only just a consumptive coagulopathy, you also have endothelial cell damage, which will lead to the same type of MAHA, the macroangiopathic hemolytic anemia. So on this one, you do have as well the ripping of the RBCs and everything. Because once you activate the clotting factor, you are making fibrotic deposition. And where's this fibrotic deposition going to go? You're going to see a lot of it upon the endothelial cells. And that'll lead to ripping of the RBCs. Yes. Yeah. So definitely, Mona, check this out. Now that we're on the same topic, let's look at this. What I've just mentioned right now was that through DIC, through the process of DIC activating the coagulation cascade, we activated it. If we activated it, we were able to promote fibrinogen conversion to fibrin. So we were able to make fibrotic deposition. This fibrotic deposition will accumulate and cause a microthrombi. That's what I'm trying to tell you guys. Microthrombi. There is no like remodeling that's going on here. This is something that is irregular. There's lack of remodeling. So what's happening here with this microthrombi? Any kind of RBC that goes by its path will get ripped. This leads to schistocytes on the peripheral blood smear. This leads to an increase in LDH. I think is it LHD? LDH, like dehydrogenase. Yeah, I'm good. A decrease in haptoglobin. Haptoglobin is like, it's there to pick up the remnants of the RBCs, of anything that has gotten destroyed. So whenever it's picking up the remnants, it won't be present. So we would see a lower level of haptoglobin. You should also have an increase of indirect bilirubin. So many things that you can have with this hemolytic type of anemia. Now, microangiopathic happens to affect the small vessels. Small vessels are closely related to kidneys. Notice if you grab your first aid and you check out for vasculitis, they have large vessel vasculitis, medium vessels, and then you'll have small. Notice that small has manifestation in the kidneys because the kidneys deals with very small vessels. So if you're causing this microangiopathic hemolytic anemia, you'll be affecting the kidneys. So you tend to have issues with the kidneys. So what do I mean with this? Well, where am I going with this? Well, I'll show you. In TTP, now there's this very stupid type of like way of remembering it. Very stupid, but it works. It's like, you know, the Addams family, the TTP, 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 TTP. Think atoms. So you're supposed to think atom. That's 13. I mean, it's really dumb, but it stays in my mind that way. So TTTP, TTP, 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 TTP. You think atoms, you remember atom S13. Atom S13 is a protease. Protease. So let me explain. Remember one thing. When we have endothelial cells, we have endothelial cells. Endothelial cells are super important. They have a lot of effect when it comes to immunity, our immune system, believe it or not. Why? Because when neutrophils have to make their way inside some type of tissue in order to defend us from any kind of threat, it has to marginate, right? It has to get to a certain layer. It has to roll. It has to bind eventually. Then it has to do a process called diapedesis, where it walks into the actual specific tissue. Diapedesis with Sil Lewis, both on the endothelial cell and on the leukocyte. Sil Lewis X. They utilize that to walk into the tissue. Now, where do they finally bind or go to? Wherever you have chemotactic factors, like IL-8, for example. That happens with neutrophils. So why am I mentioning this? Well, endothelial cells have a very important type of protein inside called Weibel-Palade bodies. Weibel-Palade bodies. Okay, Weibel-Palade bodies. So Weibel-Palade bodies are able to release something called two things. The W is for von Willebrand factor. The P is for P-selectin. P-selectin. You have von Willebrand and P-selectin. P-selectin basically would express itself whenever there's inflammatory effect, whenever you have, let's say, pro-inflammatory factors will increase the expression of P-selectin in order for neutrophils to be able to bind to this and then make their way into the tissue. That's how you do it. You have margination, where they align themselves. You have rolling effect, where they start to slow down and they start to roll. You have binding, then you have the whole diapedesis. Remember, you have PE-CAM adhesion factors. That's a very important process. But for now, let's concentrate on the other thing here, the other elephant in the room, which is basically the von Willebrand. The von Willebrand. So this is for like inflammation, you can tell, like acute inflammation. This is for hemostasis. Hemostasis. So von Willebrand does increase the half-life of factor 8. Von Willebrand increases the half-life of factor 8. That's something that it can do. It helps in that sense. Remember, factor 8 is part of PTT, the intrinsic pathway. Remember that? So it's going to aid in increasing the half-life of factor 8. It's one thing that it does as well. But okay, what happens? Von Willebrand, the way that it's made, the way it comes out, naturally, a lot of proteins do this. And this is a very important concept for you to understand right now. Whenever you have proteins that you can translate, remember what we mentioned before, transcription, mRNA, translation, protein. We mentioned this already. This comes from the nucleus. This is in the cytoplasm, utilizes ribosome. Whenever you translate, these proteins tend to have another process. We didn't really mention it, but there's post-translational modification. Post-translational modifications. You can modify these proteins according to what they have to do, their job. For example, sometimes proteins come out in a very long polypeptide chain. They're able to be released in a long polypeptide chain. They have to break down to smaller units so they can become functional. They have to break down to smaller units to become functional. You see this a lot with virus. When a virus creates itself many times, it comes out in a form where it must be modified. And you have proteases which modify it. Proteases are able to break it down, and it tends to unite. It tends to unite and build up a viron when we're talking about viruses. For von Willebrand, what it does is that it comes out in a very long polypeptide chain. You're able to break it down and then use it by piece. Say this is one von Willebrand. This is another von Willebrand. So it makes it functional. You're supposed to break them into small pieces. Just imagine you have a very big Hershey bar. You can't just shove it into your mouth. You have to break it down to small pieces in order to be able to utilize. That's the same idea here with von Willebrand. And this protease is specific for von Willebrand is Atom S. Atom S13. If you lack this protease, von Willebrand will get released from the endothelial cells whenever you need it to be released, but it'll be released in a very long chain. Von Willebrand. The problem with this is that von Willebrand's job is to cause adhesion to collagen. And it's supposed to be able to allow a space where platelets can bind. Allow a space where platelets can bind. So this becomes a problem now. Because now von Willebrand made its way out and it starts to do its job. It basically gets stuck. And once it gets stuck, it starts to bind the things that are rolling around in the bloodstream. It starts to basically form something that we mentioned before. A microthrombi. We're connecting it with what we said before. It itself turns into a microthrombi because it has adhesion to the endothelial area, and it also naturally wants to bind platelets. So this microthrombi starts to get even longer and larger, and more von Willebrand starts to come over here. And guess what it does? The same action, the same effect, the same problem. RBCs come through and get ripped. So now you're having basically an HUS. You're having an HUS in this sense. You're having an HUS. but the difference is that the symptoms here are going to be 5 instead of 3. For HUS, we said it was RAT. Renal insufficiency, microangiopathic anemia, and thrombocytopenia. Yes, it's going to cause those same 3 things, except it's also going to cause fever and who remembers the other one? Basically, altered mental status is what it should cause. Neurological issues. That's the idea of TTP. So that's the problem that we have with TTP. Does that make sense? Good. Yeah, that's the pathophysiology of it.